Good morning, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we would like to welcome Dr. Shilpa Gupta, a renowned practicing medical oncologist who focuses on genitourinary malignancies. She's the director of the GU Medical Oncology and the co-lead of Genitourinary Oncology program at the Cleveland Clinic. In this brief interview with Dr. Gupta, we're hoping to discuss her thoughts on 3 clinically relevant studies that were presented at ASCO and how these findings are shaping our community practice. Without further ado, let's welcome Dr. Gupta.
Thank you, Dr. Gosain and Dr. Gosain. Glad to be here to discuss these abstracts from ASCO.
Thank you for your time, Dr. Gupta. Diving into our first abstract, which is a sub-study of a VISION trial, which looked at metastatic castration-resistant prostate cancer patients that had progressed on at least one androgen receptor inhibitor and 1 to 2 lines of taxanes. Can you please share your experience in the use of PSMA testing and lutetium PSMA treatment?
Yeah, so I think this study is really a big advancement in the way we treat prostate cancer patients. And at our institution, we got access to PSMA PET sometime last year and are utilizing more. But, the logistics are not as practical as it may be. There's a long wait for the scans. But when possible, we are trying to use it, especially for patients who have a rising PSA and conventional image has been negative, and we are really kind of looking for metastatic disease. I'm not using it so much for patients who already have known metastatic disease, since lutetium is not really available for real world use. Just as a side thought, we are opening a new trial with lutetium PSMA in the hormone sensitive setting for PSMA positive metastatic hormone sensitive patients. And then we'll be doing this for all our patients that will be a part of the trial. But I am seeing a lot of usage of PSMA PET. Patients are coming to us with a positive PET scan and asking us to treat with lutetium.
And Dr. Gupta, in this particular study that they presented, they looked at how the SUV correlated to the response rate. Has that been your clinical experience as well?
Yeah, like I said, we're not using lutetium yet. We don't have access to. I will tell you that, yeah, the low SUVs on PSMA PET, we're now, discussing more and more on our tumor boards, and they seem to be more consistent with the indeterminate and not clinically significant lesions. But of course, because of the PSMA PET calling out these lesions, we are in a situation where we may be overcalling lesions, and patients get anxious looking at all that as well. So I'm glad they looked at these SUV quarters and, as to what to take with the clinical picture of the associated CT scan, and not to take everything that's lighting up on the PSMA PET at its face value.
Absolutely. Alongside this particular study, they also presented a therapy update from Australia, where they were comparing lutetium PSMA with cabazitaxel. That particular study was not powered for overall survival benefit, but we did not see overall survival benefit with lutetium PSMA. If, when you get a chance to start using this, would you use it before or after cabazitaxel?
Yeah, that's a great study. And I think, we saw that the overall survival benefit so far we didn't see with lutetium, but looks like the patient reported outcomes and quality of life was better. I think lutetium certainly has a place in treating metastatic castrate-resistant prostate cancer. Nobody doubts that. The big question is sequencing, and I think drugs like cabazitaxel, which are very active and become more and more difficult to give in the very later lines, we might want to push them up and reserve lutetium for after that, because in the study, patients had cabazitaxel also in the VISION study. So I think it's all a matter of where to fit this and not forget the use of these other very active agents also, which may sometimes be more challenging to give somebody in the third, fourth line setting.
Absolutely. And I think going back to what you said, it is very critical to hopefully have all this available in the community, the PSMA
Right.
PET, the lutetium PSMA. So hopefully it'll be readily available for us to use. Thank you for
Yes.
sharing your thoughts on that. Now we can move on to our second study. This particular study is a SWOG-initiated trial looking at adjuvant space for renal cell cancer using everolimus. Here, we know that pembrolizumab is approved. We know sunitinib is approved. Dr. Gupta, can you walk us through the study and its findings?
Yeah, so this was a huge endeavor for NCI to do this Everest trial. And, just reminding that this trial was started long time ago when we did not have immunotherapy. We did not have these other novel VEGF TKIs either. All we had is pazopanib and sunitinib and sorafenib. So this was an adjuvant study to see if addition of everolimus, which was also used in refractory setting at that time, would improve survival compared to placebo. And in this study, the patients who were fully resected kidney cancer patients within 12 weeks of radical or partial nephrectomy with PT1B stage or T2 to T4, any grade, but high grade for PT1B or any node positive disease, including non-clear cell histology, were randomized to receive everolimus 10 milligrams daily for a year versus placebo, stratified on the basis of risk group, histology, performance status. And finally, this study was reported, and the recurrence-free survival was not significantly improved with everolimus, even though the curves seemed to separate. But based on what the p-value was set up, it was not deemed significant. And I think at this point, when such big studies read out in an era where we have so many other therapies and immunotherapy in particular, which is better tolerated than drugs like everolimus, it gets out of context because even if, let's say, this did show some benefit, people would choose between pembrolizumab or everolimus, and the toxicity profile, as you know, is not the best with everolimus. Finally, we've answered the question and now can plan the next steps of whether there's a role of treatment intensification or not if this drug is ever to be used.
Dr. Gupta, in your practice, how often even you get a chance to use sunitinib in adjuvant setting, which is a category 3 indication on NCCN, especially as you mentioned that pembrolizumab is out there in adjuvant setting already?
Yes, I'll be honest with you, Rohit, I have not used sunitinib ever since the approval because we have always discussed with the patient, 1 year of a pain kind of, really toxic agent for a 1 year of progression-free survival benefit. Is it really worth it with no overall survival benefit? And to date, nobody has really seemed keen to take it, but I don't even discuss that option unless the patient is very young. And now that we've had pembrolizumab, we're not discussing sunitinib at all. So I'll say I have yet to use adjuvant sunitinib in a patient with kidney cancer.
Thank you.
Dr. Gupta, where do you see this space changing, particularly with adjuvant treatment? You brought up intensification. Do you see everolimus and pembro combination being the next step here in adjuvant settings?
I think, given that everolimus is no longer used that much, and I know in the ASCO, this was the thought, well, how to intensify this. I mean, that can certainly be looked at. We do have other novel agents now, right? Other TKIs, MET inhibitors, VHL targeting agents, which could be better combined with immunotherapy.
Now, moving back to prostate cancer, here we are looking at an update on Enzamet study, role of enzalutamide plus ADT versus ADT alone in metastatic hormone-sensitive prostate cancer. Dr. Gupta, stage is all yours.
So this is the study which was reported previously by the Australian group, ANZAP 1304 study, international cooperative group study looking at enzalutamide in metastatic hormone-sensitive prostate cancer, patients were stratified based on disease volume, whether they had planned early docetaxel or not, performance status, and randomized to testosterone suppression and the old anti-androgen agents, or the older, rather like bicalutamide or flutamide versus enzalutamide, which is the next generation anti-androgen, and the overall survival in the interventional arm with enzalutamide was significantly improved. It was not reached compared to 73 months with the control arm. And the 5-year survival, this is pretty much the updated data. We've already seen overall survival improvement with enzalutamide. And at 5 years, it seems to be 67% with enzalutamide compared to 57% with control arm.
Thanks for sharing that, Dr. Gupta. And again, I think one big message from each of these studies has been ADT alone in metastatic settings is subpar, so we need to have a combination. In this particular study, concurrent docetaxel was also allowed, and we saw that there was no overall survival benefit in that particular arm. But from PEACE-1 and ARASENS with darolutamide, we've seen that there is overall survival benefit with darolutamide or abiraterone. In your practice, when and where are you using triple therapy?
So, for patients who have high volume disease and have a lot of symptoms, I do still use docetaxel. Now, with the approval of apalutamide, that's been a lot of change in my practice. The PEACE-1 data specifically answering the question whether docetaxel and abiraterone is better than docetaxel alone, right? We know it is. Same with the darolutamide and docetaxel, better than docetaxel alone. I think the big question here, Rahul, is whether adding docetaxel is better than the novel anti-androgen alone. Nobody has really answered that question. Kind of established that, yeah, chemo alone may not be as good as adding another agent to it. But in the era of the newer agents, which are so well, established now, we need to ask the question whether addition of chemo is doing any good or not. And I think in this, that's probably, when you have enzalutamide and you're adding docetaxel, it didn't really do much. And I think designing such a study, whether it be darolutamide or enzalutamide, and answering that question specifically, or doing a 3-arm study, docetaxel versus the anti-androgen agent versus the combination, is what we need to know to answer the question. So at this point, if somebody is very symptomatic, let's say, has a really high burden of disease, and I'm planning to give them docetaxel, I know that addition of abiraterone would be a good idea. But I really don't know if not doing just apalutamide, for example, is going to be good enough or not, right? So I think that's how I take on that. And we need more data on these combinations in a 3-arm comparative fashion to know where each agent stands.
Absolutely. In that ideal world, would you also have a 4th arm with a PARP inhibitor?
Oh, yeah, that's a great question, right? Ideally, I think, I don't know why we don't do studies like Stampede, right, in the US, where you can have an adaptive trial and keep adding arms where you see the benefit. So I think you're right. Adding PARP in that setting is another option to see, because we know that in hormone sensitive setting, even in BRC unselected patients, just androgen deprivation can create an upregulation of the PARP pathway. I think that study needs to happen.
It's definitely an exciting time to be part of oncology and genitourinary oncology on top of that. Thank you so much, Dr. Gupta, for taking time to discuss these practice-changing trials and sharing your thoughts with us today. We hope the community oncologists will get a chance to incorporate this data in their day-to-day practice. Thank you so much again.
Thank you, Dr. Gosain, and I will really, I appreciate doing this with you, and thank you for doing this for your community colleagues.
Thank you so much again.